Thank you for joining the National Headache Foundation's webinar on tension headache. In today's session, we will be joined by Dr. Robert Kaniecki, Director of the Headache Center at the University of Pittsburgh. Dr. Kaniecki?
Well, thank you, and welcome everyone to the webinar this evening. This is on tension type headache, the most common headache in the population. So what I'd like to do is kick this off with a few opening slides, and if we could advance to the next one. We'll talk about specifically making the diagnosis of tension type headache. Now, in general, people think of tension headache and tension type headache as equivalent, and unfortunately that isn't always the case, because the term tension type headache often carries with it a link directly to stress, whereas tension type headache is a headache disorder that may or may not be triggered by stress and is characterized by specific features. So we use the word tension type headache to designate a group of patients who are experiencing headaches that generally last a few hours to a few days, and the pain and associated features are listed above. So on that slide you can see that these are generally headaches that are both sides of the head. The pain is generally steady rather than throbbing. It's unaffected by movement, and it's mild to moderate in intensity. So on a scale of 1 to 10, typically in the 2 to 7 range. And with those headaches, we have neither significant nausea nor significant sensitivities to light or noise. So basically what we're doing with these criteria is excluding those people that have migraine. With the severe headaches or significant sickness, nausea, or significant sensitivities to light or noise, usually you're dealing with a migraine condition rather than a tension headache disorder. Next slide. We then divide tension type headaches into two broad categories, episodic and chronic. And all this means is, do you have more headache days or more headache-free days? So if you're more often headache-free, basically averaging fewer than 15 days a month, you're called episodic. If you're averaging 15 days a month or more, or as you can see there, 180 days a year, so more than half the time suffering from headache, then you would be called chronic. And then you can see the second bullet point below each definition goes into subgroups with or without disorders of pericranial muscles, so pericranial around the head, basically scalp, jaw, neck muscle groups. So the point of this slide is to go into episodic and chronic, but also to establish that the tension type label comes mainly from the component of muscle tension that is often seen with these disorders. So not stress tension, not emotional tension, that's not why we call them tension type, but these are called tension type because of the element of muscle contraction or tightness. Next slide. This is the most prevalent headache in all age groups. This is the most prevalent headache in all populations worldwide, and it has the highest impact worldwide because of its large numbers. So although typically people think of migraine as a more disabling headache, and it often is, due to the fact that so many people suffer from tension type headache, we see a greater overall cost to society, work days lost, school days lost, other impact measures from tension type headache. Next slide. And this gives you an idea of episodic versus chronic. So episodic headache, roughly about 40% of the population in the United States. So tension type headache of an episodic nature, very common, the most common primary headache. Chronic tension type headache, somewhere between 2 to 3% of the population at large having these headaches daily to near daily. Next slide. We're going to talk about management, I suspect, this evening. So there are a number of non-drugs things that can work. We can look at trigger factor management. EMG, biofeedback has been shown to be helpful. And then other types of therapies in some patients you see they're probably effective and possibly helpful. Not definitive evidence behind any of those other things, such as acupuncture or physical therapy, but sometimes patients do achieve some benefits. Next slide. Therapy for the attacks often involves simple analgesics, simple pain relievers. So over-the-counter remedies are often quite helpful in these headaches, and that's why in studies that have looked at patients coming to see doctors for headache, only 3% or so of all headache contacts happen for tension type headache. Even though this is the most common headache out there in the population, in terms of those headaches driving patients to see doctors, this is a minority. It's only about 3%. And one of the reasons is these over-the-counter remedies often work. Ones that contain caffeine seem a little stronger than the ones that don't. And then there are other agents such as narcotics or opioids, triptans, which are a number of migraine drugs, and muscle relaxants turn out that they shouldn't probably be used in this condition. Next slide. For those with very frequent headache, we talk about preventive medications. Amitriptyline is the drug of choice, an older antidepressant therapy. It's very commonly used. And two other antidepressants, venlafaxine and mirtazapine, are second-line agents. So if you're more familiar with the brand names of these drugs, I'll cover them all. Amitriptyline is also known as Elavil. And then venlafaxine, also known as Effexor or Effexor XR, and mirtazapine, otherwise known as Remeron. However, when the other caveat in the kind of the phrase listed below, it turns out that these drugs alone, just relying on medication, can be often disappointing because they're not particularly helpful without taking other steps towards helping the headache situation. That might be my last. Next slide. That was the last. Okay, so that's it. I wanted to give you guys a brief overview of tension type headache, and at this point in time, I suspect we're going to open up for questions. So let's begin the chat.
Our first question comes from Llewellyn. How do you recommend treating TTH without causing rebound headaches?
Well, that's a good question. So the question about rebound headaches, now many in the headache world call this more officially, and it certainly sounds more official, medication overuse headache. Well, the word rebound I still love, and I think it's a great term because patients are very familiar with this term, and it's been around a long time. What rebound is, for those who are not familiar with this, is a condition where the medication itself makes the problem worse. And the analogy that I use for patients all the time is over-fertilizing your plants. That at a certain level, fertilizer is good. So for tension-type headache, let's just take ibuprofen. So for a certain amount of tension-type headache, sure, ibuprofen's good. But the old rule of thumb that many of your moms probably taught you, that too much of a good thing becomes a bad thing, well, that happens in headache disorders, specifically migraine and tension-type headache. And that's a situation where the pain relievers actually feed or perpetuate the headache. So too much of the problem, too much of the medication becomes a problem and escalates the headache. So those who used to get 10 days a month now have 15. Those at 15 now are at 20. Those are at 20 at 30, and so forth. So a gradual, often it's not very abrupt, it's often gradual over time increase in headache frequency. So how does one manage tension-type headache without getting into a medication overuse situation? Number one, use the medications that work. So the ones we're talking about include non-steroidal anti-inflammatory agents like ibuprofen or naproxen, aspirin-based products, and even acetaminophen for some people. Use drugs that work, and then limit them strictly to 10 to 12 days a month. You probably can get by with up to 12 days a month of management without running into too much trouble with rebound headaches using those medications. Now, there may be a caveat. The ones that contain caffeine, as I mentioned earlier, they might be a little bit stronger, but I believe, and our experience has shown, that they likely carry a higher rebound potential. So for those using caffeine-containing products, so lots of them combined with aspirin or acetaminophen, we tend to limit them to 8 days a month and maybe 10 in a pinch. So the ceiling's a little bit lower for those patients. So that's the key. And if patients require more frequent treatment, so you say, oh, well, they have to treat 15 or they have to treat 20, well, that's an indication for introducing steps to prevent or stabilize the headache. So it would be similar to asthma. Folks might be similar to that, or allergies. You know, at a certain point you can treat the symptoms, but after you have day after day, trouble after trouble, sooner or later you need to go on something daily to quiet the whole condition down. Well, that's what we do with tension-type headache as well. And so if you cannot limit your pain relievers to that 10 to 12 day a month level, then you might run into the rebound potential. You need to do something to prevent them. Finally, one last point. This is where often the opioid or narcotic agents become a real problem because their ceiling, instead of 10 to 12 days a month for a non-steroidal or for caffeine-containing products, as I mentioned, maybe 8, it turns out that the ceiling for a narcotic type agent may be very, very low. As few as 3 days a month may give people some trouble. So we really stay away from those. Not only, number one, as I mentioned, they're not indicated, but number two, we're really concerned about rebound in the long run with those medications.
Our next question comes from Lori. Many of my migraine headaches will last days, even with medication. After the pain has subsided, I will have soreness all the way down the side of my face, neck, and back. Is this because of tension type? What can I do to stop the soreness?
Well, Lori, what you have there is something that we, again, have a specific term for named allodynia. It's A-L-L-O-D-Y-N-I-A, and the term often is preceded by a specific adjective, cutaneous allodynia, so skin sensitivity. That is an incredibly common condition, and it may look like muscle soreness, so I understand your question of whether that's tension-type headache because of it may not have the migraine features anymore. The pain is maybe mild to moderate, and there's this muscular or skin hypersensitivity to pressure, to tension. But no, that is more part of a migraine condition. It is seen in some patients with chronic tension-type headache where there is this scalp sensitivity, and those with migraine sometimes will tell you my hair hurts or my teeth hurt, where it's something that you'd say it's not typical of what you think about with migraine attacks. But what that means, and we kind of I look at migraine kind of as a 3-stage process. Some people, first stage is more of a regular migraine where you can treat it anytime, the medication works, takes the headache completely away. And the second stage is, wow, once that gets activated, you better intervene pretty quickly because otherwise, if you wait too long, all the medicine will do is take the edge off. And then the third stage occurs when it doesn't matter, nothing you do will turn it off. It needs to kind of run its course and burn out. And once the migraine has kind of hit that stage, and that's when you mentioned it would go on for days, what you're left with is a specific soreness. And the way to think about this is, kind of the longer it goes and the more intense it is, it's a brain workout. So instead of your muscles being sore or from in your body from running, and it's a physical workout, the brain workout is generally manifested as hypersensitivity of the nerves and soreness of the nerves. So that would be most often in the scalp and face and into the neck, but sometimes into the limbs. Sometimes you even feel it further below. So how do you prevent that? Well, you want to be very aggressive. If you're a person that can get days worth of attacks and followed by this hypersensitive state, it's imperative that you catch your migraine in the first hour, maybe 2 hours at the most, with very quick-acting, strong migraine medication. And if you can, migraine-specific medications, the triptan medications, and if you can, injectables, even over any kind of pill or nasal spray to really hit it hard. So in that case, often a combination of a triptan and a nonsteroidal. So one kind of the migraine drugs in combination with an anti-inflammatory drug at the same time, that often can be very helpful too in trying to prevent that from developing.
Are there recommended natural approaches to chronic tension headache, such as diet, supplements, or exercise?
Chronic tension type headache most likely is very close on the spectrum of headache to migraine. And so for chronic tension type headache, yes, I believe that the same recommendations we make for chronic migraine, so migraine more than 15 days a month, hold true. Now, with that said, what we know is that all the data behind supplements and, for the most part, other natural approaches largely comes from the migraine field because we see more migraine patients, we have more migraine issues in terms of disability, so there's a lot more research in migraine than there is in tension type headache. Oh, it's dwarfed. I easily 10 to 1, not even 10 to 1, probably 50 to 1, 100 to 1 in favor of migraine. So a lot of the information we have gathered happens to be from migraine headache populations. However, we do find that these can be quite helpful for tension headache patients as well. So in terms of lifestyle steps, like migraine sufferers, we recommend aggressive regulation of the schedule. So going to bed and getting up at the same time with adequate sleep, but no sleeping in and no naps. Exercising every day for 30 minutes. If one is able, walking for 2 miles a day over 30 minutes. So it's not real heavy aerobic stuff, not intense, mild to moderate aerobic activity, but consistent every day, half hour. Regular hydration, 40 to 60 ounces of water a day. Looking at what you're doing dietarily, so avoiding too much caffeine, watching mostly food additives. The more processed the food, the more likely it is to be a headache issue. So trying to avoid MSG, trying to avoid artificial sweeteners, trying to avoid over-processing of substances where you look at packages and you have no idea what's inside. So the rule of thumb is the more that's on the package you can't read, the less likely you should be eating it. So the fresh things, less processed, the better. The time to spend for relaxation, that may be in prayer, that may be through meditation, that may be through simple yoga, or as I mentioned a little bit earlier, one can be, in a sense, trained to relax through EMG biofeedback. So that can be quite helpful as well. So regular sleep, regular meals with good, solid nutrition, regular hydration, exercise on a regular basis, watch the stress triggers and try to calm the nervous system down with relaxation strategies are all quite helpful. Now in terms of the supplements, we generally look at roughly 6 that have had good information in migraine, and they include magnesium, vitamin B2, coenzyme Q10, the herb feverfew, the herb butterbur root, and an antioxidant known as alpha-lipoic acid. So in a recent review from the American Academy of Neurology about migraine, again, this is from migraine studies, the research behind the butterbur root was found to be the strongest of all. So the evidence supporting its benefits in migraine. But we will advocate it for tension headache patients as well, tension-type headache patients who are interested in nutritional supplements. So that may be of use. Also, for those that have significant cervical spine components where they think their neck muscles are really tight, I recommend what we call a 60-second 6-position stretch. So this is actually pretty easy. We recommend these stretches 3 times a day so they can be done with meals. 60-second, 6-position. So each position is 10 seconds. Your neck basically goes 6 different directions. 1, it turns to the right. 2, it turns to the left. 3, it tilts to the right, which means you bring your ear down towards your shoulder. 4, it tilts to the left. 5, it bends straight forward. And 6, it bends straight up, looking towards the ceiling. So 6 positions. Each position is held for a total of 10 seconds. You turn, not with your hands, but just with your head. Turn your head in each of those positions. Maintain it for 10 seconds. And if you can continue to kind of push the stress a little bit further during the 10 seconds period of time, that works out fine. So I like doing that in addition to the other steps with patients who have a lot of cervical spine issues. And I think that adds some benefits. So number of natural things you can do, yes.
Our next question comes from Jamie. I have chronic migraines, but I also deal with daily headaches. How can chronic daily headaches be differentiated from tension-type headaches for the purpose of treatment?
Well, Jamie, if you looked at the headache that you're experiencing on a daily basis and excluded your severe days that are migraine, and you just took a snapshot of those daily headaches, I bet you would look at the criteria I put up earlier and say, hey, they look like tension-type headache. And in fact, migraine, once it becomes chronic, once it starts to cross kind of the 10 to 15 day a month range, often it starts, the daily headache or near daily headache looks either more like a sinus up front and in the face, or more like a tension headache, which is temple, side of the head, forehead, or even the back of the head. So the everyday or near everyday headache that migraine people experience with their chronic migraines looks like a tension headache. And the Europeans would then say, well, you know what? You're a person, Damie, that has migraine and tension type headache. And they would classify you with both. Here in the United States, we're more likely to look at this as a what we call a spectrum of headache that migraine people experience. And so migraine sufferers often have headaches that look like tension type, but biologically really are versions of migraine, milder migraine. So the way I approach this is, for folks like you, I would say that your milder headache that looks like a tension is mild migraine, or you can call it your tension migraine, and then your big-time headaches are severe migraine. So how is that managed? We don't manage them any differently than we would if you just consider this to be migraine alone. So we don't introduce any specific tension type strategies. This is somebody who we manage aggressively as migraine, and when we do, the ones that look like tension headache and the ones that look like typical migraine all start to improve with the therapies that we apply. So aggressive migraine management, and not necessarily, oh, I should treat migraine headaches with this medicine and my tension headaches with this medicine, because all that ends up doing is adding up the days that you're treating and putting you more and more at risk for the development of medication overuse or rebound. So to clarify what I said earlier, that these drugs have a limit, what we're talking about is total treatment days. So even if you're a person that took acetaminophen and naproxen and ibuprofen for your tension type headaches, and you rotated them, you never took, you rotate, next headache you take the other drug. Well, you don't get 8 to 10 days a month with each drug, or 10 to 12 days, as I mentioned earlier. You get 12 days total treatment. So that's the same thing for somebody with migraine, and the intervening headaches that look like tension type, you're held to the same standards. We want to keep your treatment at 10 days a month, 12 in a pinch, and that includes every anti-inflammatory treatment day, every migraine medication day. So watching out for rebound really is going to be important for somebody like you.
Joy would like to know, can a neurostimulator be used for treatment of chronic tension headache?
The neurostimulators, like the other options I just mentioned earlier, are certainly much more likely to be studied in migraine because of its level of disability and an overall higher profile in research. Also cluster. Cluster, not nearly as common, but because it is so intense and so troublesome, that one also is one that seems to be more a focus for some of these perhaps considered more invasive treatment strategies. So since tension type headache, first of all, episodic tension type headache, fewer than 15 days a month, it would not carry the level of disability that would warrant surgery, its risks, and the risks of having hardware in your body with the stimulator. Chronic tension type headache, however, has been studied with occipital nerve stimulators, neurostimulators to the occipital nerves. There are patients that do achieve some benefit with this. But interestingly, the data does not appear to be as robust as it is with migraine. That was true also for botulinum toxin or Botox injections. When they were studied in chronic migraine, they seemed to be beneficial. When they were studied in chronic tension type headache, they did not. So I don't know if in the long run neurostimulators are going to be a significant player in this treatment field. But I can say right now, evidence preliminarily looks promising for perhaps some of the most debilitated patients. And outside the context of a research study, we are not advising it. But perhaps if somebody wanted to get involved in a research program somewhere that was looking at that, and right now I don't know of anybody actively doing it, I'd have to check the websites, then that would be reasonable. But outside the context of a research study, I'm not sure for most patients that we would go this direction yet.
Lori would like to know, do treatments such as acupuncture help with tension type headaches and migraines?
Acupuncture is a treatment program that has some interesting study results that are, first, upfront, somewhat difficult to ignore. So we do see benefit, but here's the rub. The placebo in acupuncture studies also tends to be very high. So in any migraine research, or tension headache research, or pain research in general, you have to compare the success of the active treatment versus not treating them, but versus placebo, or what we call sham treatment. So in acupuncture, here's the way you would have to do it. Basically, you got a bunch of needles, and you would have to test acupuncture with putting the needles, let's say, in the right places, versus acupuncture by putting needles in random places that perhaps aren't the right places. So what you see is that both of those treatments can work. So needle application that's in a trained acupuncturist and putting them in the right spots where they know where to go, that seems to be of some benefit, but so does random needle insertion. And most of the studies have been relatively short-term, so we don't know, do the results last 6 months, 12 months, a year, beyond a year or two. And that's really what we want to know, because the tension-type headache and migraine are not conditions that are over in 6 months or 3 months. So does the prevention last? So I can say that, yeah, there have been studies, some studies have shown some benefit with acupuncture in both migraine and tension-type headache. There also have been studies that have shown minimal difference from the placebo, and that you wonder, well, then is it worthwhile to go through this or not? So individually, I think it's worthwhile considering. Even in the clinical trials where it's shown benefit, it hasn't been particularly robust. But as I mentioned earlier, with the preventive medications we have, they don't work that great either in chronic tension-type headache. And in chronic migraine, there is only topiramate and botulinum toxin, which are Topamax and Botox, which have any information and quality information at all in quieting down the worst of the worst migraine people. So there are lots of medications that seem to help relatively infrequent headache folks. Once you get to daily to near daily, the pool gets a lot smaller for the things that have shown to be beneficial. So in that setting, yeah, sometimes it's worthwhile. And fortunately, it's not usually covered by insurance. Some do get it covered by their health savings account if they get a prescription from it from a physician. But the direct, the most, and depending on your area of the country, there may be some that look at this a little more liberally. So perhaps, for example, in California or Colorado, where there may be a greater interest in, from a baseline for natural or non-drug therapies, and perhaps some of the health plans there cover this kind of thing. But I can tell you here in Western Pennsylvania, Pittsburgh area, it is not covered. But we do advise it for occasional patients. What I found is this is very operator dependent. So I believe there is a benefit above placebo, because I've seen a number of practitioners in our area do it, and I got consistently better results from one of them. So that tells me there's more than just random placement of needles, that people that really know what they're doing can provide some benefit. And so, yes, we do advise it at times.
Is mild confusion a symptom of tension headache types?
Confusion is not typically a tension-type headache, or particularly a mild tension-type headache symptom. So no, that would be unusual. Confusion or kind of trouble concentrating or thinking can be part of migraine very commonly. When we see it as part of tension-type headache, where some people talk about memory dysfunction or trouble concentrating or thinking, one thing we commonly look for is could there be another basis for the tension-type headache? So in other words, is the tension-type headache really symptomatic of another condition, one being thyroid dysfunction, or perhaps vitamin deficiencies, B12 or vitamin D, or could it be part of a manifestation of depression? Sometimes what looks like a tension-type headache can be one of the physical manifestations, one of the more common physical manifestations of mild depression. So if it looks like tension-type headache and confusion is a symptom, then we're often looking for another explanation, sometimes with a brain scan, to see, boy, is there something causing the headache and the confusion, because tension headache alone shouldn't do it. So that's where you look for. Do you have something in the brain that's causing the headaches and the confusion? Do you have something, an imbalance in your nervous system by vitamin deficiencies or thyroid problems, or could it be, a manifestation of depression? Those would be three possibilities that we would consider as we evaluated somebody with that complaint.
Our next question comes from Shirley. For what percentage of patients is massage helpful in gaining some relief from their tension-type headaches?
I would say for tension-type headache, for those with episodic tension-type headache, even if it's a bit frequent, massage therapy is helpful for the majority, but with the catch, it's almost always brief. I had a woman today who said that it helped her for about 3 days at a stretch, but that was it. And so, yes, it can be beneficial. Unfortunately, it's often temporary. Now, so I would say most people respond for a period of time and perhaps not sustained enough to warrant it as an ongoing treatment strategy. And that then gets, because of limited coverage issues, that ends up getting expensive as well. So we don't generally advocate that as a long-term strategy. In terms of chronic tension-type headache, interestingly, as I mentioned with this term allodynia earlier, there are those that get this significant sensitivity of their muscles and scalp and neck, and so they will feel worse sometimes with a massage. So in chronic tension-type headache, I would say it's more about a 50-50 proposition. When it works, again, it's almost always brief. When it doesn't work and it aggravates people on occasion, that almost always is brief as well. So the good news is even if it made you worse, it wouldn't last for longer than probably a few days or a week or so. So not enough there with massage that I've seen, and in terms of our practice doing this for 20 years, I've not seen enough there for patients for us to say, yeah, this is something we're going to recommend on a regular basis.
Our next question is from Lynn. I have chronic tension-type headaches. I have tried amitriptyline in the past, but I seem to gain weight very quickly. Is weight gain a known side effect?
Yes, weight gain is a very common side effect. In fact, the 3 different daily medicines that I mentioned are all antidepressants, and all 3 of those can carry weight gain as a side effect. So there are alternatives to amitriptyline. One is called protriptyline. It has not been studied as long or as much in either migraine or tension-type headache, but it is a similar class drug. So for someone where perhaps amitriptyline would have been a good choice, and it's something we were interested in trying, but weight gain was a problem, we'll sometimes go with the protriptyline, protriptyline, which is a much less commonly used drug, but in the same class, that it tends to be, as compared to amitriptyline, much less sedating and much less weight gaining. And so that might be in a medication to consider, even though I didn't list it among our top 3. But it's basically a sister drug to the amitriptyline, the top choice anyway. So that may be worth a go. Now there are those of the other 2, venlafaxine, which was the Effexor, and mirtazapine, which was the Remeron. Of those 2, the Remeron is going to be the more likely to cause weight gain as well. So if amitriptyline was a problem, going to one of those other 2 I've already mentioned could do the same thing. That's why I'm thinking a better strategy sometimes is to think, okay, well, something like it, but maybe fewer side effects. And in that case, the protriptyline may be worth consideration.
I was told I didn't qualify for migraine studies because I have too many migraines. Are there any studies out there for people like me with chronic migraine?
Yes, you have to look for studies for chronic migraine. So you're exactly right. The question is aimed at migraine research, and it mostly will look for those with episodic migraine, meaning once you start averaging more than 15 days a month or more, then you're going to be excluded from lots of the trials. So all the different migraine triptan drugs that were used, Imitrex, Maxalt, Zomig, Emerge, all those drugs that were studied over the years, they were all studied in episodic migraine patients. The newer drugs or the newer treatment strategies that basically have taken older drugs and changed the devices. So if you've looked at some of the more recent studies, looking at something called Levodex, which is an inhaled version of dihydroergotamine or DHE, or the Sumavel pen, which is the needle-free approach to the old Imitrex injections. Those studies have been conducted in the more recent years, but also those are studies that involve patients fewer than 15 days a month. So acute drugs for the attacks, you won't see them studied in chronic migraine. So none of those drugs will be studied in that way. However, chronic migraine studies could include, we've already mentioned topiramate or Topamax, and onabotulinum toxin or Botox. Those were studies that looked for people just like you. The stimulators, the implantable devices, also, when those studies are being conducted, they look for folks just like you as well. So what you're looking for is for studies directed at those individuals, recruiting those individuals who have chronic migraine. And for the most part, those are the ones you would qualify for.
Mary would like to know, is depression involved in chronic tension headaches?
Mary, yes, depression. So chronic tension type headache can be a physical manifestation of depression. So this gets a little tricky, actually, because there are two ways to connect the dots between depression and tension type headache. One is the primary problem can be depression, and tension type headache is the symptom. So how do we sort this out? Well, if depression appears to have been a longer issue, been around, or is significant, and we think that depression is, let's say we grade the depression on a scale of 1 to 10. You're grading it a 5 or above on a severity scale. Well, that may be a case where the depression is primary and the tension headache is one symptom of that. So just as crying can be a symptom of depression, or guilt, or fatigue, or either sleeping too much or not enough, having trouble sleeping or not, or being overly sleepy. Those are all pretty common physical or emotional manifestations of depression. And headache is one too, and it looks like tension type headache. So if a headache is due to the depression, it'll look like a tension headache, and I would just suggest to you that the depression seems to be significant. It's not minor, and it's more of an issue perhaps than the headaches themselves. On the other hand, tension type headache is biologically linked to a chemical disturbance related to migraine, and that involves serotonin. And so we believe that serotonin is at the core of a lot of these headache disorders, and that is the same chemical that does depression. So it may be that depression and headache are just two symptoms of brain chemical imbalance itself. So it's not the depression causing the headache or the headache causing the depression, but just two symptoms of the same problem. So biologically, the brain's out of balance with serotonin, let's say, and just kind of keep it as a simple example, and maybe your serotonin levels are too low, and that would be perhaps explanatory for both a headache thing and a depression thing, and maybe even anxiety or trouble sleeping. And so working on the brain chemistry and with the antidepressant approach, it seems to be an important avenue to getting people better. So yes, we commonly address it, and in some sense, it really, in a way, does not matter, because the drugs of choice for chronic tension type headache are antidepressants anyway, and you just have to make sure that headache doses are often lower than depression doses. So if somebody's depressed, we need to make sure that we get to a dose of the medication that can help the depression as well.
Colleen would like to know, is jaw clenching or night grinding a common cause of chronic headaches?
Jaw clenching, teeth grinding are often linked with TMJ trouble and temporomandibular joint dysfunction, and that can look like tension type headache. So one thing you would need to exclude is the problem actually more TMJ trouble than anything else. But independent of that, yes, as I mentioned at the opening, that tension type, the word tension comes from muscle, and the muscle tightness or tension can be neck, can be scalp, can be jaw. So common to see that link between jaw clenching and teeth grinding and tension type headache. Amitriptyline in that group is often very helpful. It's a drug that's given at night. It has a little bit of a muscle relaxant property. I know those that have a lot of TMJ trouble are often given something called cyclobenzaprine or Flexeril. And although I did counsel early on that muscle relaxants alone are not particularly helpful for tension type headache, for those that have a TMJ piece at night, there are many physicians that advocate using that kind of a product to help with it. So, yep, commonly see the overlap. And like the depression story, the headache may be causing the tension in the muscles and the grinding, or the grinding can be aggravating the headaches. It may be bidirectional, so the connections may be back and forth. So working on both can be of benefit. So using approaches towards tension-type headache while also addressing the grinding piece itself with a splint or one of those NTI devices that might be able to help prevent the grinding from occurring.
Our next question from Molly. If I get a headache from lack of or poor sleep, is that considered a tension headache?
Most commonly, yes. So sleep deprivation, however, can trigger a migraine. So what the trigger itself is not necessarily indicative of the headache that follows, because there are some that cluster patients, for example, that sleep deprivation can trigger one of their attacks. So just because it's triggered by sleep deprivation doesn't mean it's tension-type headache. But if you have sleep deprivation triggering attacks that are mild to moderate, bilateral, steady, aching or pressure-like in origin, without nausea, without light and noise sensitivities, lasting a few hours or a few days, if you get headaches that are triggered by that and by sleep deprivation and that sound like that, yes, it's quite common that you could have a tension-type headache. And what looks like a tension-type headache is then also commonly seen in the mornings in people who have sleep apnea. They have sleep disruptions all night, and in the following morning they wake up, they have what looks like a tension-type headache, but once they're up and around a little bit, that headache tends to fade. So yes, sleep deprivation can be a trigger for tension-type headache, but just because sleep deprivation causes the headache doesn't mean, so it doesn't trigger specifically only tension-type headache is the point I'm making.
Anne would like to know, since she's often able to stop her headaches by practicing relaxation techniques, does it mean that the headaches are tension-type headaches?
No, Anne, it could be migraine as well. So just as the trigger of stress could be seen with either migraine or tension-type headache, the benefit of relaxation, kind of interceding between stress and headache, can be seen with either migraine or tension-type headache. So it can be seen with either, and therefore, no, not specific to tension-type headache alone. But it's great. That's why we teach relaxation strategies, because if you can beat the headache without a medication, how wonderful.
Our next question is from Jenny. How safe is Botox for chronic headache treatment? Are there many known side effects associated with this treatment?
Well, Botox is a treatment that has been approved specifically for chronic migraine and no other independent headache condition. So not on the tension-type headache menu. The specific question about safety, it is considered to be a very safe avenue. The known side effects are largely local. So obviously when you're injecting anything, local reaction to whatever substance you have, swelling or irritation of the tissue. You can have the local discomfort. It is a medication that relaxes or paralyzes muscle for a period of time. So that means if a certain muscle near the eyeball is paralyzed, you could get a droopy eyelid. If muscles near the throat or neck are paralyzed too aggressively, you can get trouble swallowing or perhaps difficulty holding the head up. We've had a lot of patients we've used jaw injections for the grinders and those with migraine and a lot of jaw muscle component. And we found that, if we give too much into the jaw muscles, they can have trouble chewing. So yes, they're largely either local reaction to the medication being introduced through the skin and the needle, or related to the effect of the drug, well, the biological effect, which is relaxation and weakening of muscles. And so sometimes if you relax them or weaken them too much, it can be a little bit of a problem. So the good news is with any of that, it's over and pretty much the effects have worn off in 10 to 12 weeks, good or bad. And I've not seen in well over 5 years of me using this in chronic migraine, and other subsets of one called cervical dystonia. I have not seen, thank goodness, any significant side effects that were beyond the ones I've just described.
Our next question is from Laura. Often my headaches start with swollen muscles in the back of my neck, much like baseballs on either side of the stem. Is this a lead-in to tension-type headache, migraine, or both? Or is it a symptom of my fibromyalgia?
Yes. So just leave it at that. So yeah, can it be a symptom of fibromyalgia? Yes. Fibromyalgia, we don't think of much of that. We kind of think about the body and not the head. So fibromyalgia can then extend to the neck, but once you get to the head, we don't look at head as fibromyalgia pain for whatever reason. So headache, once it's added on, then it would matter, well, do you get severe, sick, sensitive to light noise headaches? You got migraine. If you get more milder, mild to medium, non-sick headaches, non-sensitive to lighter noise, or not much sensitivity to lighter noise headaches, well, it's more likely tension type. And so that neck problem can be a lead-in to either one of those subtypes of headaches. So could be just neck problem itself, and could be related to fibromyalgia and other issues there, kind of neck and below the head, or it can be a lead-in for migraine or tension type headache.
Our next question is from Matt. What would you recommend as far as biofeedback helping chronic tension headaches?
Well, the chronic tension type headaches, relaxation, cognitive and behavioral strategies, and biofeedback all can be helpful. The problem is coverage and cost. So what do I recommend to start off with? Well, usually what we suggest is getting, if we can find a therapist that is trained in this area and we can get reasonable cost access to these types of treatment strategies, we'll access those. If not, then we look for kind of less expensive alternatives where one can get CDs and attempt to train oneself to learn these progressive muscle relaxation techniques. EMG biofeedback, you can't do yourself. I mean, EMG is electromyography. That's it's similar to what many of you may be more familiar with nerve studies or nerve conduction studies. But this is a situation where you get needles inserted into the muscles, and one is trained to relax the muscle because of the feedback from the needle noise. So the needle's in the muscle, it's from an audio, and you're hooked up to a speaker, and you can hear how active the muscle is. And then you work on these strategies to relax it. So in a sense, you're training your body, your brain, to relax your muscles via this muscle feedback sensory experience where you hear it on a speaker. So the more relaxed you get, the less the muscle agitation is noted on the speaker's sound system. So it's great if you can get it. It's a very effective way of training people how to do this. But as I said, you find limited access to practitioners and limited coverage when it comes to insurers. So like the treatment, dislike the fact that we, unfortunately, are really hamstrung to get it covered. So often it's a matter of, can we get a type of CD or program from somebody where you can learn it to do yourself. So I just had somebody today, for example, that started yoga and went to a yoga instructor and found, these were ways that her muscle component was significantly better with a yoga program. And she went from 30 days of headache per month down to 8 over the course of about 4 months. And she had been daily to near daily for 8 years, but got involved in a yoga program, did nothing else differently. And so, unless it was just a random benefit that was unrelated to the yoga, it was that seemed to work. So ways of getting the nervous system to relax could be EMG biofeedback, could be other training you can get from a therapist, could be including kind of talk therapy, could be through a CD or a book, or could be through a yoga instructor, or it could be from a clergy person or or a minister, or you get somebody with a religious background who might be able to, through a prayer type of setting, get you into a better place. So a lot of avenues. It's just a matter of finding the right one for you.
Our next question is from Gail. I now have fibromyalgia and chronic migraine. This adds additional pain days. My preventative meds help, but what can I do for pain when I can't take pain meds?
Well, that's when you have to look to these non-pain strategies like relaxation approaches. So non-drug ways of pain management, because when you're in the same, you're under the same rules, the same guidelines as somebody who doesn't have fibromyalgia. So those with chronic migraine, well, those with episodic migraine coming 10 to 12 days a month, those with chronic migraine 22 days a month, and those with chronic migraine and fibromyalgia where they may have pain every day, that you're under the same guidelines. I mean, we need to restrict your pain medication intake to 10 to 12 days a month, and as before, really avoid the narcotic or the narcotic-like agents, because they are tremendous accelerators of the migraine condition. So fibromyalgia, how is it managed? They actually look at the data, an aggressive exercise program, and that's hard. So what you're asking is, how do I deal with the pain? How do I treat the pain on the days I can't take pain relievers? That's an important question, but really the second question you should be asking. The first question is, how do I prevent my pain from getting that bad so then I don't need to go to pain relievers? So pain prevention is paramount in somebody in your setting. And although I know, taking care, it turns out about 40% of chronic migraineurs will have fibromyalgia. So we deal with this issue all the time. And I will tell you, not only from the data I've seen in research, but from my patients' experience, if you do not exercise, and I'm talking that 30 minutes, 2 mile a day floor, if you're fibromyalgia, you really need to aim for 45 or 60 minutes. And I know you're going to be tired, you're going to be achy, you're not going to be, the next day is going to be horrible, but gradually working up an exercise program over the span of several months, getting yourself aerobic exercise between 30 and 60 minutes a day. If you don't do that, you will be very unlikely to get better. The ones that do versus the ones that don't are almost 90% versus 10. I mean, it's a dramatic difference. So the exercise piece is enormously important. Not 100% successful, nothing ever is, but I will tell you, the chances of improvement are in the 90% range, and that means a 50% reduction in all your trouble, not 100% resolution. But significant improvement is achievable, but it's got to be a combination of natural and medical approaches, and the natural piece, for sure, first step is the exercise piece. Now, the antidepressants often are very helpful for both migraine and fibromyalgia, so those are often used in conjunction for both conditions. So first step is an exercise program. Second step is the antidepressant class. Third step is then pain management strategies, usually anti-inflammatory pain relievers, and then when necessary again, or when possible, relaxation, as the one patient mentioned earlier. If I can stop my headache with relaxation, is that a good thing? And does that mean tension headache? Yeah, doing that with migraine, trying to do a relaxation approach and preventing the headache from escalating that way sometimes can be real helpful. So it's a tough spot because you're in, you got a double whammy when you have pain in the head and the rest of the body too. But the more aggressive you can be with the non-drug approaches, the better you're going to do.
It looks like that's our time for the evening. I'd like to thank you, Dr. Kaniecki, for joining us, and thank everyone for their wonderful questions.
Yeah, that was great. Thanks so much. Boy, that went by very quickly, didn't it? So thanks so much. My thanks to the National Headache Foundation for the opportunity tonight. It's been a pleasure here with the audience, and it's been fabulous. You guys have really nice questions. I hope we got to most or all of them. I know we probably didn't get to all of them since it's only an hour, but appreciate the time you folks spent online. You are involved, actually, since you've gotten access to this webinar, you're involved with an organization that is fantastic. The National Headache Foundation is my preferred organization to send patients to for access to information, and it's because of resources like this, I think, that can be quite helpful for people dealing with their headaches. So thanks so much to the NHF and the invitation. Thanks so much for the folks that have run this meeting tonight, and thank you all for your attendance.
All right, have a great evening, everyone.